This morning, we're going to talk in a more serious way about how we're doing on measuring and rating providers on patient experience, in particular patient-centered care and compassionate care. And we're going to talk about where are we now in measuring these really important aspects of care, what measures already exist, are they reliable, where do we need to do more work. We're going to talk about how we're doing communicating this information to patients and families. Do we have information that's actually helping people find patient-centered and compassionate care? And then to pick up on one of the things that Barbara just talked about, how are these measures being used to actually help providers in ways that are helping them to improve these essential aspects of caregiving?
Lord Kelvin, most famously known for determining the correct value of absolute zero, once said, when you can measure what you are speaking about and express it in numbers, you know something about it. So as consumers, we're quite familiar with quality measurements and consumer ratings of all sorts for goods and services that we purchase all the time. Most of us have used these for things like our cars and other big-ticket items. Yet we lack access to meaningful measures to help us know something about some of the most intimate and personal experiences of our lives, our health and our health care. So Kelvin suggests that if we are to express something in numbers, we must first know what we are speaking about. So it's important to consider what quality measurement and compassionate care mean for patients within the context of patient-centered care, if we are to provide measurement that's meaningful to them. So we can and must do better. If we provide ratings for patients to use as measures of quality in healthcare, especially if we are to measure the quality of compassionate patient-centered care, which is inherently multidimensional and complex. I'm not convinced most people know what we are speaking about when we use these terms. So if we create measures of quality compassionate care, we must include patients in the development process. Let patients help us unpack these terms to create patient-reported measures that are clear, answerable, efficient, and relevant to them. Ultimately, the measure of quality compassionate care should reflect an experience that resulted in outcomes that matter to the patient and those closest to them.
One of the questions is, are there enough measures? I would say there's actually quite a few measures, questions out there. We don't really need that many more questions. Barbara alluded to the first survey in Massachusetts. I was one of the founders of the Picker Institute, which developed that institute in collaboration with MHQP, and that had questions about emotional support. And leave aside what we all would get into a definition. We spent a whole day last November talking about what the definition is, but I think if you saw the bundle of questions, you'd say there are a lot of questions about not just information and respect, but emotional support, responsiveness, and things I think you would call compassion. And by the way, the Picker development of dimensions of patient-centered care was incorporated in the Institute of Medicine report, many of you are familiar with. And one of the cardinal features of patient-centered care is emotional support. And they could have easily said compassionate care. I think there would be agreement that that's quality care. HCAHPS doesn't have those questions. They're on the cutting floor.
And the Ken Schwartz story is compelling. But it also reminds me of my brother-in-law's story, Larry. He died in 1982 of metastatic cancer in Kansas City. He did not get compassionate care. His physician wasn't compassionate. The system wasn't compassionate. Some years later, my father-in-law died of metastatic cancer, and he did get compassionate care. His physician was compassionate, and the system was compassionate, in large part because he received a lot of his care at home from his family and from hospice. So this is an incredible opportunity. But this is very tough work to do. As Barbara says, it's very expensive. You all have stepped up to this more than anybody else. And so it's very challenging work to do. Is it possible to do? I think it is. I think we know that consumers trust doctors. We know that doctors can communicate well. Interestingly enough, it's not clear that patient experience is correlated with patient quality of care. It's just a very interesting domain that a lot more work can be done in, and I think compassion in many respects could be a missing link. The second aspect I'd like to mention is, we don't have compassionate systems. So we may have compassionate physicians, but I think it's the exception when they're working in compassionate systems. And in fact, I think we have to think about the definition of compassion, including a compassionate physician must be tirelessly trying to change the system they're in to also being compassionate.
My feeling, I'm going to keep this very short, to John's point that the correlation between patient satisfaction and outcomes is pretty iffy, regardless of the desires and claims. There was a study published last year in March in the Archives of Internal Medicine. It was based on the experiences, the medical experiences of about 56,000 patients who were surveyed for their satisfaction in the middle of the survey to see how their satisfaction correlated with their medical experience, and it was determined that the people who were most satisfied died at a 26% higher mortality rate, consumed prescription drugs at a much more accelerated rate. The cost of care was much higher. Does that tell us, does that send a simple message? It certainly doesn't. It doesn't tell me, no, we can never incorporate a patient satisfaction measure into best hospitals. But I'll make this one point. In that same paper, there is a statement to the effect that it may be difficult in engaging with patients for doctors to spend the kind of time that they would like to spend with them to talk about those options. In a Health Affairs paper in 2011 that Beth and Julie co-authored, there's the simple statement that 53% of physicians surveyed reported spending less time than they wanted to with patients. If you then layer on top of that reality, that office experience, a requirement that doctors do something that will have to take more time than they spend now, on top of the fact that they already feel that they can't spend enough time, you have a very difficult situation.
The question is not, is patient-centered care correlated with quality? Several people made this point. Patient-centered care is quality of care. It's not whether it's correlated with quality of care, it is quality of care. There's a lot of reasons to study those associations, but you have to be very, very careful. And I could cite you 20 studies that show not just the inherent value of patient-centered care, but the relationship to compliance, the relationship to follow-up, the relationship to appropriate response to symptoms, the relationship with other aspects of care, and as I said, in a big national study, the relationship to outcomes such as survival.
I'm struck by the frequency with which we measure something like patient-centered care in the context of the physician and patient. And I want to remind us of the variety of people who come in contact with patients across the course of their care. And so I'm always a little concerned that we put some really high value on measuring something that would suggest that the quality of something within a hospital system or other kinds of environments is actually tightly tied to the physician-patient relationship solely. So I think that I would want to caution us around that, because I think especially when you get outside of the hospital environment, typically that's not the physician that's really carrying the weight of some of that quality relationship. That said, I think the other piece I would just like to suggest is that when you're suggesting to patients about their experience or their satisfaction with what one would perceive to be patient-centered care, I want to be careful that we understand what their their definition of that might be, because I don't think that those of us in this room who use that word, have it flow off our tongues all the time, we have an understanding of what we think that means. I think when you start to talk to patients, it's probably going to be a little bit less clear to them. So I think that that's an important component. And the only other thing I would suggest is that compassionate care, as was just talked about, I think there's an expectation that at end of life that will occur. We know certainly from the work that I've done over the last 30 years that it doesn't often occur, but that it's a time when most of us think it should occur. And so I think we need to be careful not to assume that we relate compassionate care with end-of-life care, because then there's this assumption that, okay, well, that's going to be taken care of then. What about all the care prior to that?
I want to be clear about something. I feel a little bit about compassionate care, however it's defined, the way I did about the hospital compare process measures when they first started coming out in 2006, and I started looking at the compliance figures of 85 and 90 and 92% and so on, and I figured, these don't mean a lot. These are low-hanging fruit. These are measures that people deserve to know that a hospital does well, that people should get an aspirin if they come to the ER with heart attack symptoms, and that surgical antibiotics should be started at a certain time and ended at a certain time, and so on. They should almost be taken for granted. Now, I'm not saying that compassionate care is meaningless. It's not at all. But I do think it should be taken for granted. I think every patient in this country, whether we're talking about in an office setting or an ambulatory surgery setting or a hospital setting as an inpatient, deserves compassionate care, deserves good communications, deserves full information, deserves options, deserves discussion. That's not the same as saying that it should be a metric that's incorporated into other quantitative data.
I'm going to ask one other question, then I'll open it up. And this picks up on something that Sally just alluded to. So I unfortunately have been having my own journey with medical care in the last 2 weeks with my 87-year-old mother who had surgery and had what is so euphemistically called an adverse event. And while she's gotten some really extraordinarily compassionate care from some places and some extraordinarily non-compassionate care from others, what's really struck me is that what's been missing for her is really compassion across her entire journey through the medical system. The surgery, the hospital, the rehab, and most people have actually done their job really well, but somehow the sum of the journey is less than each individual part. And so I think it's really in those cracks where people feel lost and abandoned and that no one is really responsible for them.
Let's get the insight of people who are actually holding that thread and get a sense from them, where are the gaps, what's keeping you from getting what you think you need, where is the lack of compassion from this point to the next point across that journey. And that's where we can actually begin to measure and understand what we might begin to change.
We really need to take a more longitudinal view of that voyage, and the reason we don't do that is it's very hard and very complex. So to those of you in the room who manage large health systems, I'll put out the challenge to you that there are a number of people that if you were to say, I'll make a commitment to following my patients from the inception cohort when they first have this test through time and are willing to work with someone to build the system, to go down that voyage and try and understand the nuance and the history and the total experience. There'd be all kinds of people who would love to work with you on that.
To bring a sort of a different perspective to what Paul just said, even in a clinical context, it's been very difficult to figure out how to measure process. Handoffs and adverse events and other things that are partly outcome and partly process. Really difficult to measure. And if you're looking for a kind of a continuity of compassion measure as opposed to continuity of care, then that's even harder.
What Ken described as compassionate was not, this exorbitantly expensive care that we talked about. And I understand everyone here who's a provider is under incredible pressures. But there's so much more we could do without spending one more second or one more dollar. I think it's an onus upon us to do that. I agree, we need to worry about time, we need to worry about money, but there is so much more that we could do to be more compassionate to our patients, to our colleagues, to our loved ones, that we really should get on with that work.